Hello again, and welcome to part 2 of MedQuest Test Prep's edition of Biostatistics and Epidemiology. This section we're going to focus on study design, bias prevention, and clinical trials. First, we'll talk about the different types of study design. Starting at the bottom, we have case series, cross-sectional, case control, cohort studies, which can be prospective or retrospective, randomized clinical trials, and meta-analysis. It's important to note that anything from a cohort study down is considered an observational study, and that the validity of each study increases as you move up the list. I just want to make a quick note on the exception of meta-analysis. The validity of a meta-analysis is going to depend heavily on the individual study designs of the studies that are composed within the meta-analysis. So that's just something to be aware of when considering validity of studies. So let's delve in and start with talking about meta-analysis. A meta-analysis is when you have a group of different studies and you pool them together to create a net effect. So in this case, I have a couple of different images showing you studies A through E, and those are all going to yield to one large effect. Meta-analyses are really useful when you're trying to resolve any kind of conflicts in literature. Unfortunately, it can frequently be subject to publication bias. And the reason for this is because studies that have significant findings are more likely to get published than studies that don't have significant findings. So it's possible that meta-analysis gets subject to publication bias just by virtue of pooling from studies that have already been published. Next, we can talk about randomized clinical trials. This occurs when you take a group of individuals who are somewhat similar to one another. You can randomize them to receive an intervention or treatment, or to not receive an intervention or to receive a placebo. This is often called the control group. And every individual control group and what they look like are going to depend heavily on what your intervention or treatment is. So an ideal randomized clinical trial will make the two groups as similar as possible so that they only end up differing on the particular intervention or treatment that you're aiming to look at. The benefit of a randomized clinical trial is that it is considered the gold standard for research studies. You're able to make causal inferences because you have a very controlled setting, and you're able to apply this to your patients because the data is considered to be so strong in randomized clinical trials. The drawback is that these can be very cumbersome, can take a long time, and can be very expensive. So they're not always practical for investigating all of your research questions. I just want to quickly diverge a little bit to talk about different phases of clinical trials. Because usually when we think of randomized clinical trials, we often think of drug trials and pharmaceuticals. This is going to help you with determining things to do with patient management and how you're going to treat your individual patients. There are several different phases that you need to be aware of for your STEP exams. The first is phase 0. This really focuses on metabolism of a particular drug and is conducted within a single patient. The second is phase 1. This is based on safety, and this is typically done in about 10 to 20 healthy volunteers. Phase 2 moves on to look at efficacy, and this is performed in hundreds of patients, typically with the particular disease or problem in question. Phase 3 is conducted to confirm the findings of safety and efficacy and additionally compare them to a control group. So now phase 3 is really when we get into the randomized clinical trial world of pharmaceuticals. This is performed on thousands of patients. That leaves us with phase 4, which looks at the long-term effects of drugs. And again, thousands and thousands of patients, but now taking them outside of a controlled clinical setting, and that typically consists of ongoing monitoring of safety and efficacy of a drug. Next, we're moving into talking about the observational studies. The first and the most valid is called a cohort study. This is where you take a particular group of people and you follow them forward in time to see who develops a disease. Now, one quick note on this is that you can have a cohort study that does not follow forward in time necessarily. This is called a retrospective cohort study. The most important thing in identifying a cohort study is that you're starting with one cohort of people who are very similar. Now you're looking at those people who have a particular risk factor or exposure and those who do not, and you see who develops the disease and who doesn't. The reason a retrospective cohort study can be helpful is because cohort studies that are prospective in nature take a lot of time. So maybe you don't want to wait 20 or 30 years to see whether or not a disease develops. In this case, what you can do is you can go back in time and you can select a group of people at a particular time point, then fast forward your time artificially and see who developed the disease. The most important aspect of a cohort study is that the disease status is not known at the beginning of the study. This will give you an estimate of the incidence and can also estimate relative risk. We're going to talk more about these measures in part 4, so just sit tight for now. The other important aspect of cohort studies is that they're not good for studying rare diseases. And when you think about it, this makes intuitive sense. If you have a disease that's very, very, very rare, then not only are you going to be sitting around for years and years and years to see who develops it, but you probably need thousands and thousands and thousands of patients before you detect even one case. So a cohort study is really only practical for diseases that are a little bit more prevalent in the population. The case control study design is sort of the reverse of a cohort study. In this case, you are starting with a known disease status, and then you're going back to determine the particular exposure or risk factor in question. This is going to give you a calculation of the odds ratio and is good for studying rare diseases. The reason this makes a lot of sense is because if you have a disease that's very, very rare, again, you don't want to wait for years and years and years and require thousands and thousands of patients to detect it as you would in a cohort study. In a case control study, you can hand select the individuals with the particular disease and then compare them to controls. Now, a note on case control studies is that the similarity between cases and controls is very important for determining the internal validity of the study. So one method that's frequently done is called matching, where individual subjects with a disease will be matched to their controls on certain other variables, for example, gender or race, age, other factors that could potentially influence the relationship between the disease and the exposure or the risk factor. Subjects can be matched based on that. It's not always a requirement, but it is something that will add to the strength of your study. A limitation of case control studies is, again, that it's retrospective. You can't really make any causal inferences. The same is true of cohort studies. You're not in a controlled setting, so any other factors could come into play with regards to the relationship between your exposure and your disease. A cross-sectional study is used to assess one particular point in time and can give you a measure of disease burden. It can measure the prevalence ratio, which is the prevalence of a disease in people who have and have not been exposed to a particular risk factor. This tends to overrepresent chronic disease and underrepresent acute disease. This is because patients who have a chronic disease, for example, diabetes, are going to be living a long time with that disease, so you're more likely to capture them at any given specific point in time. This is in contrast to patients with acute disease, for example, the flu, where you're much less likely to capture all people who have the flu at any given point in time just because the flu is a much shorter disease course. Again, cross-sectional studies can't be used to make any kind of causal inferences. This is purely based on an association between a particular risk factor and a particular disease. Now that we've gone through each individual type of study design, we can start to talk about the factors that go into a high-quality study. So first is adequate randomization. Really, this just comes down to whether or not a computer algorithm was used to randomize your subjects into treatment and control groups. This ensures that there was no bias in terms of group assignment. The second is allocation concealment or blinding. So a lot of times in research studies, you hear the terms double-blinded or single-blinded. This just ensures that study investigators that are observing the particular subjects don't know which treatment they're allocated to, and that's going to minimize their bias in terms of what they're looking for. In a double-blinded study, the subjects themselves are also blinded to the treatment group that they're receiving. This ensures that, again, there's no bias based on the particular outcome that you're hoping to see. Dropout rates and reporting are also very important in determining whether or not the study has a high quality. So you want to look specifically at whether or not dropout rates between treatment groups and control groups differed in any significant way. So for example, you might have a drug that's very, very efficacious, but has horrible side effects. Now all of a sudden you have all of these patients who are dropping out of that treatment group just because of the intolerable side effects of the drug. So it's important to understand how the dropout rates are differing and why they're differing. And this really comes through in how transparent a given study is on what they're reporting for each individual participant. Reporting accuracy is also really important. So here you want to look at how accurately study investigators are measuring what it is they're seeking to measure. So for example, if you wanted to know about patient weight loss, it makes a lot more sense to go ahead and measure patients' weight over time rather than have a subjective report of a patient saying, well, I lost this much weight or I weigh this much, because patients are much more likely to lie about their weight. Baseline similarities is also extremely important, and this is something that comes up again and again on test questions. Before you do anything with your study, when you're looking at treatment and control, intervention, you always want to make sure that the subjects between your two groups are similar. This means that before you do anything, Group A and Group B are going to look similar on all the important measures that are related to your outcome. So this could be gender, this could be age, etc., etc. Because what might end up happening is that maybe you have healthier subjects in your treatment or intervention group and less healthy subjects in your control group. Now this could overestimate the benefit of your treatment itself just by virtue of the fact that you have healthier people in that group. So baseline similarities are very important and will help you to assess whether or not any selection bias was present. Also, having an appropriate statistical analysis. So again, don't get so bogged down by unfamiliar statistical terms, especially if they pop up on your tests. It's important to know the ones that we reviewed in part 1, but aside from that, it's really just about understanding where researchers are coming from and seeing whether or not they use the appropriate statistical modeling in order to answer the question that they're seeking to answer. Let's come back to another question. Study investigators are interested in determining whether individuals with hereditary nephritis, also known as Alport syndrome, have specific genetic mutations in COL4A genes that predispose to disease. The gene frequency of Alport syndrome in the United States is estimated at 1 in 5,000 to 10,000, which suggests that there are approximately 30 to 60,000 affected individuals. What is the most appropriate study design to help answer this question? So again, we have 5 choices of study design, all of which we've already reviewed. But the most important thing to gather from this question stem is to notice that Alport syndrome is very rare. In the United States alone, you might only find 30,000 cases. If you decided to choose a prospective study design, something like a cohort study, now all of a sudden you need to enroll 10,000 patients before you're able to detect one who gets Alport syndrome. So this is very cumbersome, very impractical, and doesn't make any sense. Additionally, because your question is about risk factors and has nothing to do with an intervention, you wouldn't even worry about choosing a randomized controlled trial. Recall that we did say that case control studies are best for studying rare diseases because you can hand select your diseased individuals at the beginning of the study. This means that answer choice C is correct. The reason that answer choices D and E are incorrect is because they don't have as high validity as a case control study. So cross-sectional and case series studies aren't really going to allow you to make as strong of associations between the genetic mutation and the disease itself. Next, we're going to move into talking about bias. This is a diagram that's meant to illustrate that bias can occur at any point in the trial progression. It can occur at planning, at implementation, and at data analysis and publication. So understanding the different types of bias that exist and where they occur will make you much better equipped to assess the internal validity of any research article. Perhaps one of the most important types of bias that will come up again and again on your tests is selection bias. This is the non-random assignment of participants to groups, and this is overcome by matching or randomization. So again, we've already talked about matching when we come to case control studies. This ensures that your treatment group and your control group are as similar as possible, which means that you can make claims based on the association between the exposure and the outcome and be reasonably reassured that it's not due to some third factor that you haven't accounted for. The same is true of randomization. If we randomize subjects into treatment and control groups, then you're much more likely to be able to say, okay, this effect is genuine as opposed to due to something that I haven't accounted for in my analysis. Anytime that you suspect selection bias in a study, this means that your study results are not generalizable, and this means that it lacks internal and external validity. So let's talk about different types of selection bias. This often becomes a source of confusion for students because selection bias is not just one thing. There are many different subtypes of selection bias. The first and foremost, and what we typically think of being selection bias, is called sampling bias. This is a systematic bias in the method of subject selection. That is to say that you are selecting your subjects in a biased way. So let's say that I wanted to look at a group of individuals from a nursing home and I'm trying to make claims about the population at large. That really doesn't make a whole lot of sense. That is an automatic sampling bias because now my nursing home patients don't represent the larger population. It's only a good idea to use nursing home patients if you're trying to make claims about nursing home patients. So it's important to consider the context of your study when determining whether or not sampling bias is present. The difference between selection bias as a whole and sampling bias is that sampling bias is specific to when you are selecting your subjects at the time and the manner in which you're selecting your individual subjects for study participation. Selection bias can occur even if you manage to randomly select patients who will represent your population, but then you unevenly distribute them into treatment and control groups. So again, as I mentioned before, maybe you put all of your healthier people into the treatment group and all of your less healthy people into the control group. That is a form of selection bias, which is also known as channeling bias. Bergson's bias is another type of selection bias, which occurs when hospital cases are compared to hospital controls when the exposure increases the chance of admission. So I kind of remember this because I think of Bergson as being like an older doctor wearing a white coat, and so that's how I remember that it relates to hospital cases and hospital controls. But the more important thing to notice is that if the exposure increases the chance of admission, then that means that your controls are more likely to have the exposure because they were admitted. So now, when you're trying to compare the incidence in the cases to the incidence in the controls, it becomes a lot more difficult to get an accurate odds ratio because your controls in the hospital are more likely to have the exposure than your controls outside the hospital. So that's something to have in the back of your head. Self-selection bias can occur when certain types of people might be more or less likely to volunteer for a particular study. And again, this means that subjects were not randomly selected, but it was all volunteer-based. Loss to follow-up, which is also called transfer bias, is another type of selection bias. This occurs when a study feature causes the intervention group to have unequal follow-up losses compared to the control group. So again, if there's a strong adverse effect to the particular treatment, it's likely that you would have many more people dropping out of your study within the treatment group as a result of that adverse effect. Interviewer or observer bias occurs when the study investigator systematically treats subjects assigned to different groups or with certain risk factors differently. So again, think about an observer observing a participant. That's how basically pretty straightforward for how you would remember observer bias. This is overcome by blinding to treatments and blinding to interventions. So we talked about this before. The less the study investigator knows about the treatment that the individual patient is receiving, the less able they are to focus more on certain things based on what their hypothesis is. Hawthorne Effect is another type of bias. This is sort of the flip of observer effect. So if a subject knows that he or she is being observed or investigated, his behavior and his response can change. So this is overcome using the placebo. So again, kind of blinding the individuals themselves to treatment. It's not always possible, but the extent to which it is possible, we try to do it. Recall bias occurs when patients with a particular disease or outcome may be more likely to remember certain details about their disease course. There's actually another type of recall bias which has a time component, which is to say that patients are more likely to remember things accurately if they happened closer to the time of the study compared to things that happened further back in history. Either way, those are both forms of recall bias. This is overcome by using a prospective study design and validated patient questionnaires. This is really going to minimize any kind of recall bias. Compliance bias occurs because compliant patients tend to have better prognoses regardless of their preventative activities. So this is really interesting because there was a study that was conducted that gave all patients a placebo pill, and they looked at the patients who had reported taking the pill at least 75% of the time to the patients who took it 25% of the time or less. And they found that the patients who took it at least 75% of the time had an improved survival over those who took it 25% or less. And remember, this was just a placebo intervention. So this shows that there is an element of compliance bias that may come into play in certain research studies. Misclassification of the exposure or outcome is something that we touched on earlier when we talk about the factors of a high-quality study design. This occurs when there's a poorly defined use of a proxy for what you're trying to measure. So really what your job is as the reader of research studies is to determine whether or not you think the measurements they used are actually measuring what they're supposed to be measuring. So using non-objective measures, so subject self-report, for example, will increase the likelihood of misclassification of an exposure or an outcome depending on the study that you have in mind. Again, a larger variability leads to a decreased ability to detect an effect, which can increase the likelihood of type 2 error. So this is going to be extremely important if you have a very poorly classified exposure or outcome. You're going to get data points that are all over the place, and that will make you less likely to actually detect the effect that you're trying to detect. So I want to take a minute to talk about confounding, because this is also something that's very high yield for board exams. Confounding occurs when you see an association between an exposure and a disease or an outcome that is not a true association. So I have an example here. There was a time where observational studies were performed that showed that caffeine use increased the risk of having a heart attack. Later on, randomized controlled trials came in and actually found that this relationship could be explained by the fact that coffee drinkers were more likely to smoke, and that smoking was actually the cause of increased heart attack rather than the coffee itself. So this is a case where variables appeared to be associated, but were actually confounded by a third variable that explains the true association. You can limit confounding by matching or randomization. So again, randomized controlled trials continually again and again become the gold standard. You can also, as I said before, match subjects based on race, gender, any other kind of variables that you think might be important to explain what you're trying to explain. Confounding should be contrasted with an effect modifier, and this is a really important distinction for you to be able to make. An effect modifier occurs when a third variable actually helps to explain an altered effect based on the first variable. So in this example, I have that smoking increases the risk of lung cancer. What we know is that the combination of smoking with asbestos exposure exponentially increases an individual's risk for lung cancer. In this case, asbestos exposure is an effect modifier because it increases the effect of smoking beyond what would be expected from smoking alone. So again, effect modifier is important in explaining the relationship between two variables, whereas confounding means that the original variable was actually not at all related to the question. Let's come to another example question. A randomized control trial is performed to investigate whether opiates provide superior pain control to NSAIDs or physical therapy for osteoarthritis. Subjects with osteoarthritis were recruited from a senior assisted living facility and randomized to receive 4 weeks of either opiates, NSAIDs, or physical therapy once weekly. Validated pain questionnaires were administered at the beginning of each week, and serum ESR and CRP measurements were obtained as a secondary outcome. Researchers concluded that NSAIDs provide both superior pain control and decreased serum ESR and CRP in osteoarthritis relative to both opiates and weekly physical therapy. So now we can look at the question. Which of the following is a concern regarding these conclusions? A, the presence of other chronic diseases may be confounding results. It's definitely a possibility, so let's come back to this answer. B, use of surveys creates the possibility of recall bias. Well, we did mention that surveys do increase the risk of recall bias. However, in this question stem, we know that A, the questionnaires were validated, which is extremely important in eliminating bias from surveys in research studies. And B, we need to look at what the questionnaires were used for. So in this case, the questionnaires were used for assessing pain. And really that's the only and the best way to assess pain, because you're not really subject to recall bias, you're just asking about pain in that particular moment. So B isn't the correct answer. C, inadequate randomization. Well, there's no reason to believe that the subjects themselves were not adequately randomized. So it's probably not the right answer. D, inappropriate measure of the outcome. Well, again, the outcome is pain control. This is done using validated pain questionnaires. Again, anytime you see the word validated attached to a questionnaire, that means you don't have to worry so much about inappropriate classification of outcomes. So D is not the correct answer. Last choice is E, a high likelihood of type 1 error. Again, there's no reason for us to believe that this is the case. You're not really given enough information within the study to make a determination about the likelihood of type 1 error. That leaves us with answer choice A, that the presence of other chronic diseases may be confounding results. So again, you're selecting your sample from a nursing home. So it's possible that these patients have pain coming from other sources and other diseases besides just osteoarthritis. Another quick note that I want to make on this question is the point of validated questionnaires. All that means is that the questionnaire has been written and tested in multiple populations and has been shown to have good internal validity. So that's kind of all you really need to know about validated questionnaires. Always make sure you look out for them, because anytime you see a study that is not using validated questionnaires, you need to call into question the internal validity. I want to make a quick note on intention to treat analysis, because this is something that also will come up within research studies. This is performed when participants are analyzed according to the group to which they were randomized. That is, if you were randomized to treatment, you're analyzed as treatment, and if you're randomized to control, you're analyzed as control. This is going to preserve the benefits of your randomization and eliminate the possibility of selection bias. This is in contrast to something called as treated or per protocol analysis, where subjects are analyzed according to the actual treatment that they received. And sometimes research publications will publish both sets of analysis. But intention to treat analysis is really considered to be superior to as treated analysis. And we'll see why on the next slide. So let's take an example. Let's say you have 20 patients who receive drug A and 20 patients who receive the placebo. In the drug A group, 10 are lost to follow-up, and there are 4 strokes. In the group B group, 0 are lost to follow-up, and there are 4 strokes. Now, if you look at the incidence in group A, you would say that 4 strokes occurred out of 10 people, right? Because 10 lost to follow-up. So this is an incidence of 40%. In group B, the incidence is 4 divided by 20, or 20%, because all of your 20 patients stayed in the study and you know that there were 4 strokes. What intention to treat analysis does is that it ensures that you can account for the 10 that were lost to follow-up, because you don't know if those 10 were all healthy or if all those 10 had a stroke. So intention to treat analysis, again, preserves that and allows you to make a little bit better and more accurate conclusions about what you're likely to find, especially in cases where you have this differential loss to follow-up across the groups. And again, this is just an exaggerated example. Next question. Several observational studies were published that demonstrated that hormone replacement therapy reduced the risk of coronary artery disease in peri- and postmenopausal women. Subsequently, randomized clinical trials were performed that revealed a slightly increased risk of coronary artery disease among women on HRT. Which of the following could be a possible explanation for this discrepancy? Answer choice A says the randomized clinical trials had a larger sample size. You're not really given any information in the question stem about the sample size of clinical trials. Additionally, having a larger sample size means that you are more likely to detect significant effects. However, in this case, we're comparing a negative effect to a positive effect. We're not comparing no effect to a positive effect. So in this case, answer choice A is probably not correct. Choice B, the observational studies controlled for confounding. Well, we don't actually know whether or not they controlled for confounding, but even if they did, again, we're going from a negative relationship to a positive relationship. So whether or not the observational studies controlled for confounding wouldn't really explain this difference in a meaningful way. Choice C, the observational studies lacked power. Again, there's not really enough information in this question to determine whether or not the studies lacked power. Choice D, the observational studies use less robust statistical testing. The robustness of statistical testing is just based on the test statistic itself. Any time that you're using any kind of modeling and test statistic, the robustness of statistical testing tends to be better when you assume a normal distribution. It's less important that you understand what that means or how that comes into play, but just know that the robustness of statistical testing across different study designs should not be a factor. That leaves us with answer choice E. The observational studies were prone to selection bias. This is true because we know for a fact that is a byproduct of doing these lesser valid study designs. So randomized controlled trials are considered the gold standard. This makes answer choice E correct. This concludes part 2. Stay tuned for part 3, which is going to focus on outcome measures, and then part 4, which will delve into sensitivity and specificity.